This winter, more than ever, with COVID-19 still circulating, we need help to reduce all avoidable risks. You can help protect the NHS, social care and loved ones by getting the flu vaccine. You may be eligible for the free vaccine at your GP or local pharmacy if you are over 65, pregnant or have a long-term condition. Find out if you are eligible at nhs.uk/staywell. Children up to Year 7 can get the free nasal spray at school or through their GP if they are below school age. If you are not eligible for the free vaccine, you can pay for it at your local pharmacy. The flu vaccination does not give you flu. It reduces the risk of catching flu as well as spreading it to others. If you had the vaccination in the past, that will not protect you as the flu strain changes every year, so you need to have a new one this year. It is also important to wash your hands often with warm water and soap. Use tissues when you cough or sneeze and bin used tissues as quickly as possible. Thank you for helping to protect yourself and loved ones this winter.
After a year like no other, I'd like to ask everybody in Nottinghamshire to make a pledge for a brighter, greener future. While spending more time at home, we've all appreciated and recognised the benefits we are afforded by having green spaces, clear water, trees and wildlife around us. So let's look forward into the future and save these precious natural resources. Now we can all play a part in this by reducing our waste, reusing where possible and recycling whenever we can. So why don't you join with me this January in making a Knots Recycle pledge, and in return Viola will donate £1 for every pledge to my chosen charity, which for this year is My Site Knots. Make a pledge. Make a Knots Recycle pledge and help raise money for this worthy charity while helping the environment. Thank you very much.
We get a weather update at 11 o'clock from the Met Office through to our gritting controller at Newark. He'll relay that message to the four foremen, which I'm one of, and then we relay that down to our crew that we are in charge of. That'll give you the time that we're supposed to be in the yard, the spread rate that we're supposed to be spreading at, and the weather forecast and what they're expecting and what time we're going out due to the weather. We go out with a said lorry full of salt, could be up to 10-12 tonnes on the back, and away you go. You spread it down, and you want to be putting it down a couple of hours at least before the forecast of it's going to drop cold, to help the traffic crush it down into the tarmac, and then hopefully when it goes freezing, it'll not freeze, it just moistens it up again nicely. It's all down to the weight of the traffic and everything else. It's quite a pleasure to be out there. You know you're doing the best that you can. You're putting the salt out there. You're trying to make the road safe. you're just in your own little world. You know what you've got to do. You put the radio on, heater's nice and warm, and you're away and enjoying it, and off you go. It's peaceful.
I can really recommend being a foster carer for Notts County Council. There's always someone walking the journey alongside you, whether that's other foster carers or social workers. It really helps to provide stability and consistency for children who really need it, and that's really rewarding as a foster carer.
Roger and I have been fostering for 35 years. We do deal with challenges, but to say we've been doing it for 35 years to me proves that it's not impossible. We learn an awful lot from these young people, and even now we're still learning.
As a foster family, we care, we want to make a difference, and we get so much fulfilment from fostering. The satisfaction of making a difference is something that money can't buy. Just seeing the smiles on the children's faces and helping them reach their potential is wonderful.
We work as family workers within the fostering service for Nottinghamshire County Council.
I really enjoy my work. I really enjoy meeting lots of different foster carers.
You know, we get to know the families, we get to know the kids, and we care, basically. It's important as it is to them that the kids are getting the support that they need.
A lot of people said to me they would like to be a foster carer, but there's something stopping them. I had that as well. And we decided just to jump in and do it and see what happened. And for us, it's been the best decision we've ever made.
It's been a fantastic decision, it really has, yes.
Once people start to become a foster carer and take that leap to do it, they'll understand how much it gives back, not just to the child, but how much it empowers you as well.
I'm Leon, I'm a care leaver, and I've been in care since I was 8. I've been with the same parents since, and they're amazing. Like, they are my foster parents, but I do class them as my parents, my mum and dad. All a child wants really from a family is to be supported, loved and cared for, and know they're there because they're wanted. From personal experience, I know the difference it's made for my life.
We always say that we foster as a whole family. It's not just us who are the carers, our children are involved in that. And even now, people express concern about the effect on our birth children of foster caring. I think we need to kind of get past that and dispel that myth, because actually the overall effect on our children, I think, is positive. They're learning new skills, they're gaining empathy, they're interacting with children from different backgrounds. For a long time, we didn't make use of support care, and we wanted our child to settle into our placement and not feel pushed out, but it's actually been really helpful for us to start to have support care.
We've known Zoe for a number of years, and it's meant that we got to know her foster child. So for her, it's been like coming for a sleepover rather than a feeling she's coming to another family. I got into fostering for Notts County Council, and it was something that I've always wanted to do. But working full time, and my husband also working full time, we thought it's not really going to be something we can do now. But after
We're live, Chair. Thank you.
Thank you very much, Noel. I would like to welcome you all to this meeting of the committee, which is being held remotely, with the majority of members joining the meeting from their own homes. For the benefit of the broadcast, I will now ask the clerk of the committee, Noel McMiniman, to explain who is attending today and the practical arrangements for this virtual meeting. There you go.
Thank you, Chair, and good morning, everyone. As well as Councillor Girling, the other members present in the meeting today are Councillor Martin Wright, the Vice Chair, Councillor Richard Butler, Councillor John Doddy, Councillor Kevin Greaves, Councillor David Martin, Councillor Liz Plant, Councillor Kevin Rostance, Councillor Stuart Wallace, Councillor Muriel Wise, and Councillor Yvonne Woodhead. Bear with me a moment. Healthwatch Nottingham and Nottinghamshire is represented at today's committee by Ajanta Biswas, and Martin Gately, the Council's Health Scrutiny Lead, is also in attendance. We are joined by a number of NHS colleagues to inform our discussions today. These are Dr. Amer Ali and Katie Moore, who are joining us for the Dementia Strategy Update item, and Lucy Dadge, Nina Ennis, Sarah Fleming, Lewis Atoria and Philip Britt, who will be joining us for the tomorrow's NUH item. The meeting's been held in line with the requirements of the Coronavirus Act 2020. So please do bear with us if we experience any technical issues. If we do lose any members from the call temporarily, then officers will seek to assist in getting them reconnected as soon as possible, hopefully without the need to halt proceedings. Officers will inform the meeting if they are unable to rectify the problem, and we may need the meeting to be paused or adjourned temporarily. During discussions, I would ask that members refer to the agenda pack page numbers when referring to points within the committee papers. Thank you, Chair. That's it.
Thank you, Noel. All right, okay, item 1 then, the minutes of the last meeting held on December the 15th, 2020. Are we happy that's a true reflection? Yeah, thank you very much. Apologies for absence.
All members of the committee are here, so full house. No apologies.
Okay, item 3. Do any members or officers present have any disclosable pecuniary interest to declare? Do any members or officers present have any private interest, pecuniary or non-pecuniary pecuniary to declare? That's easy for you to say. Item 4 then takes us on to the Dementia Strategy Update, Nottingham University Hospital. I welcome Dr. Amer Ali and Katie Moore from NUH to the meeting and invite you to introduce this item in more detail. Thank you very much. You're on mute. I'm going to take £1 off everybody that I have to say that to today.
Good morning. Good morning. I'm Katie Moore. I'm Head of Patient Public Involvement, and I lead on the dementia strategy with Dr. Amer Ali at the Trust. So if I just take you through the paper, then I'm going to hand over to Amer, and then we're quite happy to take any questions. Is that okay?
Absolutely fine. Thank you.
Perfect. Okay, so we've provided you with an update on the dementia strategy work that we're doing at NUH. And just to recap, the strategy was developed in line with national and local best practice back in 2019. It's a 3-year strategy. We work closely with our patients and local community to develop this strategy. And it is focused around 3 areas for dementia. So it's around raising awareness and understanding, early diagnosis and support, and living well with dementia. And that's in line with the national dementia strategy, Living Well. So basically, it's a 3-year strategy, and we have divided it up into 5 elements within the hospital. So we look at coming into hospital, ongoing care in hospital, leaving hospital, end-of-life care, and people training and culture. So to deliver that strategy, we have pulled together a steering group within the organisation, and on that group we have representation from all the clinical and corporate departments in the hospital, because dementia affects everybody, and it's wherever we go in the organisation. So we've got our estates department involved, we've got our strategy department involved in it, and also we've got a voice of the patient carer on that strategy strategy group as well, and this is via a variety of sources. So we have we work closely with the Alzheimer's Society, Dementia Action Alliance, and a variety of internal and external groups. So the current situation where we are nearly towards the end of year 2. Year 2 strategy, you won't be surprised to hear, has got delayed slightly in response to the pandemic. But we are really pleased to see that we have still managed to achieve, make some significant improvements in some areas. The most notable one is in training. And there's NHS England has set out a framework which actually promotes that all staff have dementia training. We're really lucky that we've actually managed to put this together this year. So all our existing staff have got to undertake this training, and then all new staff coming in have to do this training. We set quite an ambitious target. We only started this in April, and at the end of December, we'd actually achieved 74% of our staff getting that training, which is a massive achievement and will really help because, like I said, dementia patients and the carers are all over the organisation. So it is key that every member of our staff has an understanding of the requirements of those patients. The other area that we've done some significant work on is trying to improve the environment. So we did an assessment. There's a thing called the King's Fund Environmental Assessment for Dementia Patients. We assessed our wards on that, and we've identified some priorities for improvement. And they are quite simple things, but they make such a difference to our patients. So it's about orientation, signage, making sure the clocks are up in the right environment. Very, very simple, but they can often get lost in an acute trust. So we have put some significant work in on that, and we are improving the environment as much as we can. We've done some work around improving the assessment techniques for patients when they come into the organisation, and we are putting a new electronic system in place which will help with the assessment of patients wherever they come into the organisation. It will be on the digital system, so anybody will be able to access that. Development work is well underway on that, and we're hoping to make that live towards the end of March. As I say, significant work has gone on during COVID to support our patients at this particular time because it's a really vulnerable group of patients. We have had the support of the local community here quite a bit. A lot of the visitors that we had in and activities that we gave to our patients had to stop because we couldn't have visitors in. So we've done some work with Wellsprings musicians, and they were funded by the Arts Council, and they've provided some virtual entertainment for our patients, but also some virtual treatments for our patients as well. Significant piece of our work has been supporting our carers and patients to stay in touch during the COVID pandemic. There's lots and lots and lots of national guidance on that. We did have to restrict visiting completely for a very, very short period, but soon as the national guidance advised that we could do, we opened it up to patients with dementia and their carers. We have put an extensive range of resources available on our intranet pages about keeping in touch, and put things in place like messages to loved ones so people can send cards, messages in virtually, and we'll make sure that goes to the patients. We've also put things like FaceTime. We say that every patient should be offered the opportunity to stay in touch every single day, and we support our patients to do that because we're well aware with some of our dementia patients, it is quite difficult for them. So really most of our work this year has been around supporting our patients, the communication during the pandemic. We've reviewed our year 2 milestones, and we will be continuing over this quarter to promote care involvement and support, working closely with local carer organisations because they provide a lot of support, so our role is to signpost onto them. Our information sharing between all the organisations. We're doing quite a lot of work around promoting and training use of the respect forms and end-of-life care. We've remained active partners in the Dementia Alliance, and we continue to work with them closely. So I think that's about just a quick whistle tour through where we actually are. Do you want to come in, Dr. Ali?
Yeah, thank you, Katie. That was described very well. There are little pieces of work that are also happening. For example, we are preparing to train some of the people to tier 2 level now, and discussion is already in place how to deliver that training, how to select the group of staff that needs to be trained up to that. And we've engaged the learning and development team in NUH to assist us with doing that. And there is a chief nurse fellow nurse who is joined, who's going to help us deliver this level 2 or tier 2 training. Like Katie said, a number of iPads and iPhones have been given to the wards to communicate with the carers, and patients are able to do that. So that's another aspect of dementia work that we are delivering. And as Katie said, tier 1 training is going better than expected. We were always hopeful that we'll achieve 100%, but 74% at the end of 8 months is great achievement, I think. The other milestones, we've had very good engagement with even pediatric surgeons who came to me, why do I need this training? And I said, your patients will have grandparents and they might come to visit, and they might fall. So you have to be trained as well how to communicate with somebody who is a loved one of your patient who needs some information, but you need some background information. And when he did that training, he came back to me and said, thank you for letting me into that training. So it is important that none of the staff members should be excluded out of it. It doesn't matter where they work. I'm happy to take any questions, or Katie can answer most of them.
Lovely, thank you. I think you're absolutely right that they can come from anywhere, and dementia doesn't mean you haven't got other ailments as well, does it? And that's the thing about it. And I think in the past, because of the symptoms of dementia, they can be quite aggressive sometimes because of their frustration. They're seen as troubled patients rather than, oh, there's something wrong here. They've got dementia and they're struggling. And I think that's absolutely right. That the training goes ahead, and it's good that the example that you gave about the surgeon that came to see you, that's absolutely incredible, because we all know that they all speak with each other, and he'll be telling people how good the training was and it's worth going on, which creates that momentum, doesn't it? So thank you for that. Right, I've got Councillor David Martin first, please.
Thank you, Chair. Morning. Yeah, thank you, Mr. Chairman. I wholeheartedly welcome this report. According to Alzheimer's Society, the effect of lockdown on symptoms of dementia has been dramatic, and I welcome the fact that this report recognises that COVID-19 may still be a major issue, but positively looks forward. The most common symptoms that people living with dementia reported during this period have increased since lockdown began, were difficulty concentrating, memory loss, agitation, restlessness. Only 1 in 5 reported living with dementia reported having seen no differences to their dementia since lockdown began. This is according to a recent survey by Age UK. Lockdown has seen families having to live apart and having reported seeing dramatic increase in symptoms of their loved ones because of that separation. Each and every carer of somebody looking after somebody with dementia in Nottinghamshire should be congratulated, because it is a very difficult job. I've heard stories from my division in Selston of elderly people coping with their husband, wife, loved one living with dementia during lockdown. It must be harrowing for them to see the person that they love slowly deteriorating. That's why I'm so pleased to see the appendix to this report covering issues suffered by carers looking after people living with dementia, whilst positively looking forward. And of course, one of the other great issues, well, 2 other great issues are actually, and I'd like if you could give me a bit more of an explanation of how it works. And I know Dr. Doddy will probably agree with me on this. One of the biggest issues I find is, especially with people, elderly residents with dementia who are living alone, repeat prescriptions, because that's a real issue. Because when they've got dementia, they often forget that they've got to go and get them again. They think it's a single course. So I'd like to know what the resilience pathway is and the methodology for checking that repeat prescription gets to that person with dementia. And also as well, it clearly shows the importance of blister packs, because they are another real major issue. And I've heard rumours across Mansfield and Ashfield that some pharmacies are not producing blister packs anymore. And I know we've looked into this before, but I want an assurance that this is being kept up, because blister packs are very important to people with dementia, and it's a real significant step. I actually had a resident who lives just down the road from me who forgot to get his repeat prescription for blood pressure, and subsequently kept falling over, passing out, fainting, and he broke his jaw, he broke his arm, and nobody knew why. And then one day he fell over, and we went into his property, carried him back in, got the ambulance out, and found a receipt for prescription medicine that he'd not had since the previous August. That's why he kept passing out. That bloke's now in a care home and he's still alive 3 years later, because we hammered home and made sure he got the repeat prescription. So that's why I'm keen to make sure that there is a resilience pattern in place for people like that. Thank you.
I can start with the first option, the blister packs. So I wasn't aware of issues in primary care, and I think I will raise that with the primary care colleagues and the ICS system to find out if that is an issue and how they are planning to address that. So I will take it back to them. The issue of resilience, of how do you make sure that your patient has not collected medication and they have forgotten to take medication. That is also a primary care issue. What we are doing in the hospital when somebody comes in, and this is part of the coming into hospital work stream, is that every patient who's admitted over 65, a pharmacist goes through their list and compares that list to when they have taken the last prescription. And that information is passed to the medical team looking after them and saying that this patient has come in, but they have not got a repeat prescription for X number of weeks or months. So that's a way to highlight that issue in the hospital. And that's the difference we've made part of the dementia work stream, that coming into hospital includes a pharmacist. Our steering group includes a pharmacist, and we discuss these issues. And so it's called medicine reconciliation, and we are doing it for every over 65 patient.
Can I just come in on that? Sorry for jumping in here, David. But when you was explaining about the pharmacies look at their list to see that people are not coming in for their repeat prescription, you said that looking if it's weeks or how many weeks or months. That to me indicates that possibly there's no set time frame for that. Is there a trigger point for the pharmacist to say that Mr. Girling has not been in for his repeat prescription now for 2 weeks and need to do something about it? Or is it just a case of every now and then they put this report in that goes to somebody who looks through the report? How can you explain a bit more detail how that actually works? Because I would imagine, whereas if I'm on a prescription that, you know, it's a 2-weekly prescription or a 3-weekly prescription, it'd be completely different to somebody that needs to take something that's really serious every day, type of thing. And so I'm curious to understand how that system operates, because that to me sounds like a really good safety valve for these people forgetting to get their prescription. And Councillor Martin brought up a case where he hadn't had it for months and was fainting because of his blood pressure. So there's a disconnect there.
So, Councillor, I can only say that we work in the hospital, so I would not be able to comment on what happens in primary care. But I can assure you that I will take it back to the ICS board and explain to them that this has been raised in the oversight committee and what is the mechanism. And I can email back the team with my reply at that time. At the moment, I'm not qualified enough to answer that question.
That's great, Dr. Amar. I think it's a really important point that Councillor Martin's raised, because, it is a safety valve, and if that safety valve isn't stringent enough, then people are going to come the worse off because of it. So if you could do that, and then I'm sure that when Councillor Doddy comes on, he might comment in terms of from his point of view. Do you want to follow up? Sorry for jumping in, David. But
no, it's fine. We're all here to help people, and that's the main reason of the committee. And I think the loophole is when people transfer from the hospital after the start package is finished, and they've got onset dementia, where they haven't got full-blown dementia, or it's when they've got onset dementia, and maybe that carer has passed away or lived with a family member living close, and especially during this last year, that's been more acute. And I'm hoping that Councillor Doddy will be able to enlighten us on what they do as a practice, because there doesn't seem to be any set pattern across the county or the country even, and it's a bit of a loophole. I mean, obviously, if you're not getting your blood pressure tablets, you're going to faint, aren't you? And that's what happened. And his wife had died, and she used to be the one fetching the repeat prescription. And I think I'm almost certain I'm be corrected if you'll indulge me, but I think the primary care after they've left the hospital and the start package is over is in doctor's practice. I may be wrong, but there must be some methodology. We need to standardise some methodology to protect those doctors, because they are as busy as hell. And over this last year, it's been even worse, because the primary carers for a lot of these people have been kept away by the COVID pandemic.
Yeah, so I think this is a really important issue, and it's something that should be coordinated by all three: the pharmacists, the doctors, and the hospital. There needs to be a joined up mechanism, really. It might be there, but it might be one of those things that needs to be focused on. Like anything, isn't it? There's a system there sometimes that isn't quite used how it should be, and then by focusing on it, you get everybody joins together. So if you're going to take that back, that'd be great, Dr. Amal, and we'll see how it goes. That might be something that we want to look at in the future as one of our work programme items.
And of course, it's intrinsically linked with blister packs, because when you're not quite sure whether you took your tablet yesterday or not, that's the whole idea of the blister pack. That's why it's so important that they are produced.
Yeah, and I second that one, because I take some tablets every day and I can never remember if I've took them yet because I haven't got a blister pack. But yeah, I totally agree with that one. Anything else, Councillor Martin?
No, thank you.
Lovely. Councillor Doddy next then, please.
Yes, thanks very much indeed. I think just following on that line, the new primary care networks were funded by the government to have in-house pharmacists in every single practice within every single primary care network within the whole of the CCG, and that started this year. So the care of the person being discharged from hospital and new medication, the discharge report of every single patient is picked up by the in-house pharmacist, and they then set the scale for recalls and they put it on the screen for the repeat prescribing, etc. So the care starts the minute the person is discharged, and I've never seen something that worked so well. And it's one of those really, really successful things, having a pharmacist in every practice. They're not the pharmacists that are in the pharmacies. These are our pharmacists working for us in our surgery. And we've got 2 of them here to monitor all prescriptions when they're discharged. The second thing is that a lot of repeat prescribing is initiated by the pharmacies themselves. So they'll have things like 4- and 8-week recalls to order the drugs for every patient as they go. The blister packs are great, but it depends on the blister packs that have been delivered, been picked up and checked and brought back to the chemist to see they've actually been used. Because a lot of pharmacies will push 4 weeks of a blister pack through your letterbox, but they don't pick up the old ones, so nobody knows that you've actually been complying with them, and all you get is more and more blister packs. There is an increased use of technology, there is an increased use of families setting up Alexa, setting up electronic watches, setting up reminders for people to take the medication, so that's there. All dementia patients under quality and outcome frameworks get an annual review. People with blood pressure are set on reminders and called in on a regular basis. And a lot of these have comorbidities, which means that they're constantly in contact with the practice. So there are obviously the odd one that slips through the net, but with the new developments to primary care networks and in-house pharmacists and the emphasis on safety, that is becoming rarer and rarer. It is a problem with pharmacies in one sense that if they're not being reimbursed to do nomads, and if the time and everything involved in doing that outstrips the benefit to the pharmacy, the enthusiasm waxes and wanes. So I think that that is an area certainly that will be the integrated care system's challenge to maintain the pharmacists' interest. There was the case, I think Councillor Martin brought it up a little while ago, about pharmacies actually charging £5 for delivering nomads, etc. So that became a little bit of a challenge as well. But I think in terms of general practice, there's lots of reviews, annual reviews, quarterly reviews, in-house pharmacists to maintain that safety. I think back to the original discussion around dementia, it did get a lot more publicity this year as the footballers started to come out and talk about the development of dementia after heading heavy leather footballs throughout their career early on, and other groups recognising that certain of their occupations have led to dementia. And you had Barbara Windsor, who sadly passed this year, who contributed a lot. So the heightened knowledge and awareness of the population around the country, which again, when it's brought by large popular organisations like the FA and the Football Association, like well-known screen names, only serves to be positive and increase awareness and people's concern around dementia and increase their knowledge, etc. Us in the council, we have had and become dementia friends as we've had people out and give us talks, etc. So we're kept up to date with regards to that. From my own point of view, I was just particularly interested in two areas. Number one, as Councillor Martin mentioned, in the community, there is no face-to-face assessment at the moment in order to diagnose dementia. People are not being seen. If they are being seen, it's in full PPE and it's rare. And memory clinics, it's at least 6 months before anybody can get an appointment for a memory clinic. So through nobody's fault, COVID has stopped the diagnosis almost entirely of dementia in the community. If there is some community diagnosis, it's remote. The opportunity to diagnose dementia on a patient remotely via a video, I think is pretty difficult. So I think that we're just going to have to wait until times change. But locally here in Stapleford and Sheila Gibson unit, waits are significantly increased, 3-6 months, etc., unless there's a crisis. In terms of going into hospital, which is your area of interest, it was nice to see that you had an electronic tool which helped you to diagnose people and separate them from those with, acute toxic problems and deliriums, etc. Could you give us an idea of what that actually looks like for the patient and the ward staff and people when they're actually utilising that tool? And are we any closer to other tools such as voice recognition systems that pick up patterns of speech, etc., for the early diagnosis when people go into hospital, etc.? Probably one for Dr. Ammer. Thank you.
Yeah, so I'm going to attempt to show you what this tool might look like. Let me find it. I wasn't expecting to show it, sorry. Right, maybe I'll have to just describe it rather than show it to you. So we are using what is called a tool called 4AT, and it's mainly for delirium diagnosis. It screens for possibility of delirium, whether the person has delirium or is likely to develop delirium. So as soon as patient over 65 comes into an emergency department or any of the admission units, the nurses or junior doctors will be prompted by their nerve center. So if you imagine, the nerve center is now our tool where all the assessments are done. So it's a handheld device, it's on an iPad or an iPhone. and it will flash on this. To complete the assessment, you have to go through a certain number of boxes. You have to assess their VTE risk, their falls risk, their pressure ulcer risk, the nutrition risk, continence, everything. So part of that, we are going to include testing for delirium and risk of delirium. So if you score a positive on any score positive, so 1 or 4, then the nurse or the doctor will be prompted to say that you need a bigger assessment for this patient who may be at risk of developing delirium or is in delirium. And then you go on to a proper assessment of delirium. But that mark will remain on the alert system. And every time a consultant or another doctor opens up that patient's record, it will say this patient is at risk of delirium. So has anything been done about it? It will just be a prompt like this. So first step is an assessment, and then a continuous prompt coming up and that prompt will inform people, and we are linking it to training. So very soon a new delirium training module is coming out in NUH, where all staff members who are working with over 65s will be prompted to complete that training, which is delirium assessment and treatment. And the delirium guideline is currently being updated, which will include the crisis situations as well, when you are dealing with a severely agitated older person who is in severe delirium or who has behavior associated with dementia symptoms. So that's what the idea is. It is currently with the IT system. We've given them the algorithms. This is how we want it to work. And they are working on it, developing the program. It will be linked to the new assessment that is coming out before March. So that's the number March date that we are hoping that it will be linked to that. What was the other question? Can you remind me?
I'm just going to go back to 1 second there, Dr. Amar. It might be useful for you to separate what you diagnose and consider to be delirium separate from chronic problems such as dementia, because delirium, you could have a high temperature, you could be toxic, it could be any sort of thing, which is only screening for confusion, but it doesn't necessarily screen for dementia. Could you just sort of elaborate for everybody present on what you use to separate the two?
So dementia, when somebody comes in and they are known for having dementia, we'll look into the SCR records and we'll know this patient. And so a tag will be put on the nerve center that this patient is known to have dementia. If somebody has come in who has new dementia symptoms, then we have what is called the rapid response liaison psychiatry team available. And I'd like to assure the committee here that their team has been expanded because of COVID, and 2 new nurse assessors have been included since COVID started, and more consultant time has been put in as well. And recognizing the fact that face-to-face appointments are not possible in memory clinics, so we are trying to diagnose and make plans for people who are coming into hospital in a crisis or newly diagnosed in the hospital. So yes, those are 2 separate items, but everybody who's coming in over 65 will have a basic memory test and a delirium screen.
Thank you. I'm going to move on to who's next? Councillor Greaves next, please.
Thank you, Chairman. Under the present circumstances with COVID, how many patients are in the ward and how many staff is there to look after these patients? Obviously, my mother suffered with dementia, bless her, at 94. But obviously she had trouble, which is a common problem, with drinking and also feeding. So my question to you, how many staff have you available to look after patients with the drinking and the feeding? And when you talk about having iPads, obviously this is going to require somebody who's suffering with dementia. A member of staff is going to be having to be there to overlook this process with them talking to the relatives or the carer that may not be able to come into hospital at the time. My question to you is, have you got the numbers? Have you got the staff to be able to do that? And if I may, also, what safety features have been installed on wards to prevent falls, for example? And if this has been done, or if it hasn't been done, how long will it be before it's complete? Thank you, Chair.
Katie, do you want to take the first question?
Yeah, I will do. Yeah, thank you very much. Regarding staff numbers and numbers of patients, it is variable. So patients are assessed when they come into hospital. There are national requirements around staffing levels, and we have to flex our staff up and down as patient need is required. So it's really difficult to give you this is the number of patients and this is the number of staff, because obviously, particularly with patients who have dementia, their needs do change. But what I can reassure you is that the patients are monitored, and where patients need extra supervision or extra time, we actually increase the levels. There's various risk assessments that are actually done. And as for meal times and everything, we do put in additional support at meal times to make sure the patients do get supervision at meal times. In regards to safety, so patients are assessed, and if they are at risk of falling, there are various observation methods that we put in place. We put in the basic requirements that are required for that individual patient at that time. We do have enhanced supervision in place. So if a patient is identified as needing that, we make sure we put it in, which is in the case of additional staff being able to supervise the patients at that time. Amma, do you want to come in with me?
So I'll answer the falls side of things. So prior to COVID, so let's go back to 2019, the number of falls was consistently coming down in the hospital, and to a point that from let's imagine from 100 we were down to 15, 16 level. So that was the extent of the work that was put in regarding inpatient falls over from 2010 to 2019. We have definitely seen an increase, and there are multiple factors for that. As Katie said, there are challenges on how many number of people are there. There are challenges of patients coming in quite unwell. There is increased in confusion level and delirium, and because of COVID. And so the numbers have increased. The trust response to that is that we have made a new committee for falls prevention, inpatient fall prevention. We have started looking at every fall that is happening at the moment. We've changed the process of how they are being reported, and we've started an engagement process with the ward teams and trying to support them how the issue of inpatient falls can be addressed. We have looked at all the policies about toileting and safe toileting. A number of falls had happened when privacy and dignity policy conflicted with the falls prevention policy. So you close the door of the toilet and let the patient be inside in dignity. And then the patient a confused patient might try to get up and fall in the toilet. So we've actually started training people and saying, this is where the two policies conflict, and the falls policy will overrule the dignity policy, and you will keep the door slightly open now, and you will remain standing there, and keep an lookout for patient who's finished their business and is going to get up. So we have taken as many steps as we could in this current climate to start addressing that issue.
Okay, Kevin.
Okay, Chair, thank you.
Lovely, thank you. I've got Councillor Mira Wise now, please.
Yes, thank you, Chair. Thank you very much for all that you've described. clearly you're doing a great deal in the hospital setting. I've just got 2 or 3 questions. One picks up from Councillor Greaves' question about staff resources. When my mother-in-law, who developed dementia, was in hospital at the Queen's, her behaviour deteriorated really in a difficult way because she was so disoriented by the distance between beds and the size of the ward and so on. And when I've been in hospital myself, once I remember being in a bay with a lady with dementia. She was agitated and just couldn't settle. So the nurse, one of the nurses, was trying to get her to have her meal and to come back to her bed and sit down. And he must have spent, you know, a good hour or so at each incident, you know, calming her down, bringing her back to the bed. So there is clearly a resource issue, not just at meal times, but in terms of staff time. And I know that at some hospital trusts, before COVID, obviously, some hospital trusts looked at I think one of the hospitals in Leicester looked at the notion of a kind of dementia passport, so that people came in already with substantial information about their situation, but also began to explore the possibility of either the paid carer or an informal family carer being with the patient all the time. I know that happens sometimes with people with very significant learning disabilities, for example, but it seemed an interesting model for people. And I know sometimes parents come in with adult children who have learning disabilities. I just wondered if there's any exploration at NUH about a carer staying with a patient. I know there's an issue about, for paid carers, an issue about whether they would still be paid at the rate that they would be paid if they were looking after the person at home, but it just seemed an interesting model. I suppose the other question is around the local alliance, which I've been part of in the past through another role. I just wondered how helpful that alliance is at bringing the plans of the local authority and the voluntary agencies together, because obviously, like yourselves, Nottinghamshire County Council has established, we've established our 3-year dementia strategy. I just wondered how much sharing there is about those strategies, so that where there can be some joined up thinking, that's being implemented, because obviously you've got enough on in the hospital itself, but I just wondered if there'd be a benefit in more partnership with the local authorities and with the voluntary sector. And Kate, you mentioned signposting, and I just wondered if there's anything further, more substantial, that we can do in partnership. So there's, it's making the best of the partnership strategies, really.
Thanks, Muriel.
Thank you.
Okay. Do you want me to respond to that? Yeah. I think your carers are vital, and that's what we promote through all our training. We have got a document that we put together called the About Me document. Yeah. So it's a document that is all about me, basically. So it lists people's likes, their dislikes, what helps them sleep well, how they like their food, hobbies they like. So it's a 5-page document, and also as part of that document, I think it's the 4th page, is actually called carer involvement, and there's a section there for carers to fill in, and it actually asks them, you know, with the patient's permission, if you want to get involved, what are the ways you would like to get involved? So it actually lists, would you like to be phoned, and if so, when? Would you like to come in? And if able to, what bits of care would you like to assist with? And we've actually listed those out. So it's meal times, washing and dressing, all those sorts of things. Now that document is available. Pre-COVID, we used to give that out to carers, yeah. But if you go to our website, we've got quite an in-depth website for carers. And that document, there's an electronic format of it. So people could actually go on, if they wanted to, complete it at home at their leisure, and then either phone us or send it in to us. So the About Me document is absolutely crucial. One of the difficulties that I will say with that is, it's like with anything, ideally it needs to be a document that works across the system, not just for NUH, because that needs to be with the person and be carried through. So we are doing a piece of work which comes on to your next point about all working together. Yeah, so we're doing a piece of work with the Dementia ICS that looks at trying to standardise an About Me document so that it is useful wherever that patient actually goes and wherever that carer goes. Involving carers in their care at NUH. Pre-COVID, we were actively promoting this because, you know, we do respect that sometimes the carer is really worn out, and sometimes they do just want a little bit of a break, and we need to facilitate that as well. So we are mindful of that. But yeah, we've got flexible visiting, open visiting for carers. So it was something that we were actually promoting. And one of our concerns at the moment is that because carers are so isolated, we need to offer support for them, which is why we're trying to do a lot of signposting and working together. So, for example, before I came on the call this morning, quite by coincidence, we worked really closely with the Carers Association in Nottingham. They'd sent me out a whole list of virtual events that were available for carers. So I signpost those on to the staff on the wards and actually asked those to signpost our carers onto. So absolutely, you know, that role for carers is absolutely crucial, and that's what we're doing a lot of our training about. Your second point about working together, again, absolutely key, because we only have these patients for a really, really, really short time. And ideally, the patients are much better off looked after at home and only to come to us when it's absolutely necessary, because it is so disorientating for them. Worst possible place for a dementia patient, a hospital, because it's so busy, it's not set up, all those sorts of things. We've had fantastic experience with the Dementia Alliance. We've done loads of joint events with them. Dementia Awareness Week, we did a fantastic event in Rushcliffe community. We've also contributed to a couple of booklets that we've done across the system. And what I think has actually been fascinating about Dementia Alliance work is that I've gone to meetings. We've had the Theatre Royal there, we've had the football, we've had the cricket, and we've all shared and promoted ideas, what we're actually working to do. And because we've got the knowledge of that, I can then actively promote it in the hospital. And I mean, your question, is there more we can do? There's always more that we can do. But just, I mean, our experience has absolutely been really, really good, and they've really helped us.
Okay, thank you.
Thank you, Kate.
If I can add to, sorry.
No. Go on, Doctor.
If I can add to what Katie was saying, that the dementia training, the tier 1 training, that is standardized across the system. That was agreed as part of the ICS working, that we will have one training across the system. So everybody should be trained at the same level. The other thing is, like Katie said, we are actively working with the steering group, which is the ICS steering group, and that work is filtering down to ICPs and PCNs as well.
Thank you. I've done the dementia carers course, and it's fascinating, absolutely fascinating about how you approach things, and the carers that were on that course, which tend to be, or at that time tended to be their loved ones anyway, really benefited from it. It's a really, really good course. Do you want to come back, Miro?
No, thank you both for that. That was really reassuring and encouraging. Yeah, wish you well with it all. Thanks you.
Thanks, Miro. Vice Chairman.
Thank you, Chairman. Thank you. And I have unmuted, you'll notice. I've just got a couple of questions. Most of what I wanted to ask has been answered and answered very well, and thank you very much for that. I'd like to ask a layman's question. When a dementia patient, or when a person suffering from dementia is admitted into NUH with a non-related illness, may have an appendix gone or anything, you know, are they cared for in a normal surgical ward, or are they cared for on a specialist dementia ward? That's my first question. And my second question follows the comment that I'm delighted to see how many people have been trained, 74% in such a short time, and delighted that everyone is trained. You know, even the consultants, you know, they are trained too. So I'm very pleased to see that. Can you just give us a quick flavour of what that training contains? What you're actually doing, how long it takes, and how it's been received by the staff. Thank you.
I can answer the first question about where they are treated. So the aim of the Tier 1 training is that everybody is trained. So everybody can look after somebody with a appendix, like you said. So the patient will come through the emergency department, will go through the surgical assessment area, and probably have their operation that day or the next day, whenever the surgeons feel they should be operating. And then they will be treated by the surgeons. But there is close working relationship between surgical teams and geriatricians in NUH. They can ask for help, and actually we go and visit their wards regularly during the week. So we don't have a need to transfer them to a specialist unit. Specialist unit is only one in NUH, which is the medical mental health unit, B47, and we reserve them that area for those people who have severe medical problems and severe delirium problems. So they need to be managed for both of them. But if somebody is stable patient with their memory problems, we'd like as an organization, we aspire that they should be able to be looked after at a high level in the same area where they need to be for their medical treatment. Katie, do you want to take the next question?
Yeah, that's it, which is about the training. So yeah. It is it's predominantly it's based on the NH England Skills Dementia Training Framework, and it is Tier 1, which covers basic awareness. So it's a basic awareness around what is dementia, how to actually communicate with the patient with dementia, and basically how to signpost on to support. So it gives you enough information, you know what it is, you know how to communicate with that patient at that time, or that person at that time, and then you know where to get additional signposting and support from to do it. So it's basic awareness. And the idea behind that is, so like I said, we give it to everybody. So all our porters are having it, all our consultants are having it. And also a piece of work that we're actually doing for Year 2 is to make sure all our volunteers do that training. And also we're looking at getting it in our tender requirements going forward. So all our staff in our retail outlets have it as well. The training is delivered predominantly online. It's mandatory training. It's a 45-minute that is online. For some people that don't have computers, or for whatever reason they can't access it, we have got a bespoke session that we deliver, and that's been predominantly delivered in estates and facilities for their staff to date, and probably for the volunteers that will be going forward. Is that okay?
Yes, that's lovely. Thank you. Just come back on two things, which I hope would be in your reply. We all know that dementia patients can be very challenging, and of course, because of their condition, they do forget to hydrate, and they do forget to eat. I was expecting that would probably be in your basic training, that to make sure staff would observe whether a patient is drinking enough or is eating enough to sustain them. Thank you.
Sorry, in the basic awareness, I should have covered that. It is actually covered around, it's around communication. What I meant was communicate and to look after that person. So it is actually the importance of it is in there.
Lovely. Thank you very much. Thank you, Chairman.
Does anybody that's not speaking? That's a new word, Liz.
Unmuted. Yes, thank you. Thank you, Chair. And again, apologies a little bit if some of my questions are a bit of a repetition. I have to say, this is actually to Dr. Doddy. I was very concerned with what he said earlier on in the meeting, that obviously no dementia assessments are actually going on at the moment, presumably in GP surgeries, because again, in terms of all diseases, obviously, and this one in particular, early assessment can obviously make a difference to outcomes and to a patient's quality of life. So I find that quite concerning. My actual question was, yes, absolutely, it's really good that 74% of staff have actually received that training. One of the last milestones, it was about volunteer training. You've answered it really, Katie, but I was just wondering what and how well, presumably your volunteer support has been really affected during COVID in terms of them actually being able to even to get into the hospital or not. Could you just say a little bit about that? And again, it is good, obviously, that the training is online, so really I'm assuming that's not particularly affected. And if you could just give a bit of information in terms of how many volunteers have actually taken up the training and what their role is at the moment, if there is a role for them at the moment. Thank you.
Who's going to take that, Tom?
Yeah, certainly the volunteers, yeah, they are restricted in the organisation at the moment. We have very few volunteers at the moment, and we don't actually have them on the wards at the moment. So that's why we've had to look at other ways of actually supporting patients at this time. We do have activity coordinators, staff that are activity coordinators, and they look at doing activities and supporting the patients on the wards. And also we've looked at some of the virtual stuff that staff can deliver to patients, and we've had things like colouring books that have been purchased and being brought in. They're not appropriate for everybody, but we've tried to look at a range of other things that we can actually bring into those patients. We've also worked really, really closely with the hospital's radio, and they've done shows, played music, and we can put requests in for patients to actually do that as well. So as I say, they're not on the wards at the moment. Actually doing the training, the mandatory training, that has actually only just been passed through to go to volunteers. So none of them have actually done it as yet. That's our quarter four to actually get that done, but it has been passed through, and it is available for them.
Yeah, happy, Liz? You're on mute, but yeah, I can see that you're happy. John, I'm going to let you come in, but on the proviso that it's very, 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 very brief.
Very, 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 very brief. It's just a point of clarification for Liz's point of view that we're seeing loads and loads and loads of patients. We're doing loads of assessments, and where necessary, they're being referred to the memory clinic, such as the Sheila Gibson unit. One of the last referrals I did was on the 26th of November, and they haven't been seen yet, and there's no prospect of them being seen. and we're being encouraged to continue to refer people into the service so that they go on a waiting list, but that waiting list is getting longer by the day. So the problem isn't in general practice lists where we're seeing them all and identifying them. The problem is that the diagnosis relies on a CT scan to show the brain changes that can allow you to attach a diagnosis of dementia and a form of dementia. So I think that's the difference. Everything is rosy in the general practice garden, but the community services are, quite reasonably reluctant to do face-to-face communication with people with dementia. And as I started off by saying, if you try and do that remotely, like if I was to assess you guys for signs of memory loss today, it might not be entirely reliable. I might attach the wrong diagnosis to some of you. Does that make sense, Liz?
Reasonably. I'm glad I've put very onto that. Okay, I'm going to bring this to a close now. So thank you very much for the report and answering the questions that we've given to you. I appreciate that COVID has got in the way on that. I think one of our considerations is to moving forward, and I think maybe that we'll get you back in a year, because then you'd have been well into your next part of it, and we can see what the progress is then. Are we all happy with that as a committee? Yeah, so we'll bring you back in a year's time, if that's okay, and see where we've progressed, provided that COVID's let us in a year's time, that is. But thank you very much for coming in. Thank you.
Okay, thank you very much indeed. Thank you. Bye.
Thank you, everybody. Thank you.
Sorry, Doctor. Thank you very much. Okay, item 5 then, tomorrow's NUH. I welcome Lucy Dadge. She's a very common member of this committee's scrutiny from the CCG. Philip Britt.
Regular, not common.
Well, when I said common, I thought
frequent.
Frequent. That was the word.
Regular.
Sorry, Lucy.
That's okay.
Yeah, there's nothing common about Lucy, I can assure you. We've got Lewis Vittoria. We've also got Sarah Fleming, who's head of programming, program delivery. And I'll leave it to you to do the report. Thank you.
Okay. Yes. Well, on that note, Chair, I had decided actually that to give you opportunity to hear from somebody other than me today. So, Sarah Fleming is going to just take you through where we are with the programme in general, and Lewis will talk to you about sort of outcomes, what we're hearing from our early engagement on the programme. Going to stay around, very happy to take questions. So I'm going to hand over now to Sarah just to take you through, if that's okay.
Lovely, thank you.
Thank you. So, hello, I'm Sarah Fleming, Head of Programme Delivery at the CCG, and not a common occurrence here, so nice to meet you all.
Okay. It was an error.
So, we just wanted to give you an update on the programme overall, so I'll do that, and then Lewis is going to give a bit more detailed information about where we're at with the pre-engagement work that we've been doing. So, as you already know, the outcome of tomorrow's NUH will be refurbished and/or new hospital buildings. So what these buildings need to be is actually determined by the clinical services that the hospital will provide in the future. So that's very much the work we've been doing. Our hospital clinicians and GPs have been working together since the summer to develop a clinical model, and that's what we've been talking to the public about in the pre-engagement work. So what they've been doing is they've been looking at how we will need services to work, and therefore how we will need our buildings to be configured to ensure that these services work as well as they can for our population. So clearly, any clinical model that we do propose will need to be based on the best clinical evidence that we have, and that's both national and international clinical evidence. And to ensure that we really do this robustly, we've been supported by the Clinical Senate that many of you will already know about through other pieces of work. So the Senate's made up of experts in all the clinical areas that we're interested in and that we're developing our model on. And importantly, they come from outside of Nottinghamshire, so they're from the East Midlands and West Midlands, so outside of our area. So they really look at our model and scrutinise what we're doing and use their knowledge and expertise to work with us to develop the best model we can do. So what we did, we had a Senate review on the 2nd of December. So in advance of that, we provided lots of information about our clinical model, all the evidence that we'd already used, and we sent that to them in advance so that their panel of clinicians could have a look at that. We then spent the whole of the 2nd of December in discussions with the Senate around the clinical model, really digging into some of the detail and them challenging us on what we need to do. So the Clinical Senate did support our overall model, so those principles that we've been developing, I think it is the right approach to developing our hospital services, but they recognise, as do we, that we need to do more work around that clinical model. So really start to dig into that detail around what will services look like underpinning those high-level principles that we've already got. So since that, what we've been doing is we have been continuing our work on the detailed clinical model, and that's being done by clinicians at the hospital, working with our GPs, other services in Nottinghamshire, so Sherwood Forest hospitals, our community providers, as well as that model being very much influenced by the engagement that we've had with the members of the public so far. So that's the clinical work that we've been doing, which clearly is very much the basis of this whole programme of work. As you'd imagine, this is a very large programme, so we do have a number of other work streams associated with it, and I was just going to give you a quick update on where we're at with those. So firstly, we have been engaged with an impact assessment. So we commissioned a report to understand the impact that the proposed changes of our clinical model will have on our population. This is quite a detailed piece of work. It looks at a number of areas. So it looks at environment and sustainability, so the impact that this programme of work will have on our local environment. It looks at travel, so we look at where do people currently travel from to use our hospital services, and then if we made some changes in our clinical model, what impact will that have? And that looks at both private transport, so people who use their own cars to get to the hospital, but also really importantly public transport. And the impact assessment also looks at equality, so that's any impact that we will have on health inequalities. So ideally, we want to be taking actions that will reduce inequalities, and we really need to look carefully at our clinical model to look at if there's any actions we're taking that actually might increase inequalities, and we really need to be able to address those. And then the fourth area the impact assessment looks at is overall health, so the impact that these changes will have on the health of our population. I think it's really important to note that the impact assessment is very much focused on how the proposed changes will affect our more vulnerable groups that we have in our county. So we really need to put in place actions that will address those. And our pre-engagement work that Lewis will talk about, we've also done some specific focused work with vulnerable groups, and that will continue to influence the clinical model throughout this programme. Another really key area for us, sort of links a little bit to the conversations you just had around dementia, but it's really about our workforce and people plan. So thinking about what are the skills, what's the workforce that we're going to have, that we'll need in place to deliver our hospital services in the future. So we really need to understand what changes will that mean for our staff, what are the different roles we might need, what's the training and education opportunities that we will need to provide for our staff, and think about how that also supports our local economy, so training for people who live locally as well. Another area that's key to this programme, clearly this is a long-term project, so we are looking at our activity that we're going to have in the hospital over the next 5, 10 and 20 years. So this really relies on scenario modelling. We have to use data that we've already got around our population as try to project forward. Clearly that's really difficult because there are so many things happen, but it's really fundamental that we do build a hospital that is future-proof, because this is such a once-in-a-lifetime opportunity. We don't want to get this wrong, so it's a critical part is to make sure we really understand what will our population look like and what will those needs be over the long term. Another area that we're looking at is our digital strategy. So looking at what's the best use of technology we can have, and that's both in primary care and hospital, and how that will interface. So clearly things have changed significantly during COVID. We've had a lot more remote consultations, telephone appointments, video appointments, and some of that's great, and we really need to learn what went well from that. But equally, we know that won't work for everybody. So what we don't want to do is increase inequalities for those people who don't have internet access or smartphones, or maybe just aren't comfortable using that kind of technology. So it's really about learning what works well, what provides care closer to home, but actually what else do we need to put in place to make sure we don't disadvantage people. So that's a fairly quick update on the programme as a whole. Now I'll hand over to Lewis, who's going to provide a bit more detail around the pre-engagement consultation work that we've been doing.
Thanks, Sarah, and thanks for having us. So you've had the reports on the activity we've done over the last couple of months, so I won't go through those in detail. They're quite detailed reports. I'll just give you an overview of the engagement we've done, a little bit of a summary of what we've heard, and I think the first thing to note is just to stress that the period we're talking about is pre-consultation engagement. So I think the feedback that Sarah talked about from the Regional Clinical Senate, that we need to do more work on the model, is reflecting the feedback we've had from the public. So we've been talking to people at a fairly early stage in the programme. This is a positive because it's given people an early opportunity to try and shape what the programme looks like and inform any options we might put in a consultation. But it does mean that we've had conversations at a fairly high level, and as I say, that's reflected in the feedback we've had. In terms of the actual engagement activity, we've worked with 2 external organisations. So North of England Commissioning Support Unit, who are an NHS organisation who have quite a lot of expertise in engagement and consultation, and the Local Health Watch as well, who you'll be aware we've worked on for similar programmes in the past. So we work with Health Watch to try and help us reach a broader range of communities across Nottingham and Nottinghamshire. In addition to the work that those 2 organisations have helped with, we've also been attending as many patient groups, forums, organisations, board meetings as possible. So that means talking to our provider colleagues, different health interest groups, cardiac support groups, maternity groups, as well as various health networks across the area. So a lot of activity in quite a short space of time. So the feedback from the additional meetings that isn't covered in the reports that you've had for today is aligned to the feedback we've heard in other forums as well. There's some quite strong common themes coming through. In addition to the engagement activity, we've also set up a stakeholder reference group. So this is a group that's independently chaired by the Chief Executive of Health Watch, includes people who are involved with different networks, different health communities, and the role of that group is to try and feed in the views of different communities across the area. So that's been quite a useful thing to have. In terms of the engagement we've carried out, we've had 3 public events, 6 focus groups in total across the Health Watch and the other organisations' work, a survey run by the external consultancy, hard copy and online, and also Health Watch ran a similar survey. The work that Health Watch did was mainly through telephone interview of their survey. So the feedback we get from Health Watch tends to be more detailed, qualitative and richer. You'll see from the demographic information in the Health Watch report, they have also helped us reach a much broader demographic than our other engagement activity. So essentially what we've asked them to do, which is to help us to reach out more widely across the area. In terms of what all of that has told us at this stage, so again, just to caveat, this is quite an early conversation with the public, quite a high level, but we still have had quite useful feedback. I think the first thing to say is people are broadly supportive of the model that we're proposing. So people flagging things that they are identifying would bring benefit. So separating emergency and elective care, co-location of services, making more use of community and primary care, all seen as positives. That said, the next main feedback point is that plans aren't yet detailed enough for people to really take a view, which again is reflected in some of the clinical feedback we've had. Mostly then people are liking what they're hearing about the proposal, but want more detail. There's also some scepticism about the credibility of the plan. So this is reflective of the lack of detail at this stage. So people want more information. They want to know how it's going to be delivered. Concerned about how the model will work across acute, community and primary care. Want more detail of how the services are going to fit together. In line with other engagement we've done over the last year, when we talk about remote consultations, which is a big part of the model, people are seeing benefits and also flagging concerns. So people seeing the benefit in terms of convenience, but also concern about people who may not be able to access appointments remotely. Just general access and accessibility are key themes. Transport, parking, building access come up in pretty much every conversation we've had, and also people wanting to know that specific access needs are going to be catered for. In terms of how we try and take some of that feedback into the next stage of the programme, we're in a little bit of a pause on the engagement while we reflect on what we've been told. I think the key things we're feeding into the programme for further engagement and also for development of the model is that we do need to do some further engagement. People need to start to understand the impact of specific proposals. So the next iteration of conversations need to be a bit more detailed. We need to address some of the concerns that people have about out-of-hospital care and work that part of the model up in more detail. and people are quite keen to know how physical access to services is going to work. So the first thing people want to know is how I'm going to get there, where I'm going to park, how I'm going to get in the building. And I think we'll need to broaden the engagement going forwards, both in terms of the range of people that we're talking to and the detail in those conversations. So in summary, I'd say we've started a conversation with the public, and it's good that we've started early, so we need to continue that. We're in a moment of reflection, just taking on board what we've heard so far, and the feedback has provided some good common themes for us to take on board. I'll pause at that point before questions and just hand back to Sarah, just to give us an overview of where we are, and then we can take questions on the engagement specifically.
Thanks, Lewis. And I suppose it's just to really let you know what our next steps are, because clearly, as Lewis has said and reflected in our clinical Senate experience, we are developing more detail around the clinical model. So really building on, we have these principles around co-location of services, but what does that really mean? And I think it's important that we wanted to start engagement with the public really early, because we absolutely think that that's what will shape our services. So it's not that we weren't planning to do this detailed work, it's just we need to make sure we are getting our plans informed by the public all along. So what we are doing now is working out the detail of those clinical models. Clearly, as you'd expect, our clinicians' time is very limited to work on longer pieces of transformation because of the demands of COVID. So we are trying to do this work, but we do recognise, and hence Lewis has said, we're in a bit of a pause because we clearly need clinicians to be focused on what they need to do at the moment. But that absolutely will happen, and we will really get into the detail. And I think another point that Lewis picked out was around, people have very much said they want to understand what's the out of hospital model. So we're doing more work around that to be really clear about what people could expect to have the services in the community, but also what then would happen in the hospital, because clearly they are very linked. So we very much see our pre-consultation engagement work as a consultation process throughout this whole programme, and that will continue to evolve as we develop our clinical discussions. So the overall programme of work clearly is very broad, and what this will result in is a number of options for how and where we will deliver services in the future. These options are assessed as a part of a formal options appraisal process, and that's clearly a very open and transparent process. So when we've got those options clearly defined and fully worked through in detail, and affordability and deliverability, these will then form the basis of our consultation plan that we will bring back to you before we would launch our formal public consultation later in this year. So we would hope to be coming back to you sometime in late spring with our options for consultation, and ask for your approval at that point to move forward to public consultation. And just to assure you, we obviously continue to work with our national team, because we absolutely want to make sure that we can take the most of this investment opportunity for Nottinghamshire. So we continue to work with national teams to make sure we're doing everything we need to do in the right timelines. And we'll also like to continue to work with you as our programme develops to help us shape those decisions that we'll need to make in relation to the programme, and to make sure that we really spend this money to deliver the greatest benefit for our whole population. So that's kind of the summary. Obviously, we've got a lot more work to do, and we'll continue to do that, and we'll keep coming back to you with updates so that you're kept fully informed throughout the programme. Thank you.
Thank you, Sarah. I'm now going to open it up then to members. I've got David Martin first. Please, Councillor Martin.
Yes, thank you, Chair. If you'll indulge me. I'm glad to see the work going on, and this is the right forum to put the right pointers into the right people, because you are forming a strategy for Nottinghamshire, and you know, it's a very important part of the county. So I'm going to be slightly parochial, because I'm going to talk about Hucknall. So Hucknall, in the census year 2011, had 32,000 people, 32,107 people. That was 10 years ago. So we are lucky, and this is going to be part of your information coming forward. We're in a census year, so you're going to find out exactly who lives where, right, and most up to date, and that's very important when you forming this strategy going forwards. Now, the reason I want to talk about Hucknall is because, particularly, and I think we need to talk to you need to talk to the district council really about this, and I am being parochial about it, because there are two practices there, Torquard and Wyburn, and they've got 25,000 people in them. There are recently 5,000 new homes in Hucknall, which is an extra 12,500 people. So I'm guessing that population is nearer to 42,000 now. And of course, that has a great detrimental impact on the city, Gedlin, and other areas around it, because all areas across the district are all embroiled in local building plans. Some of them have got the local plans through, some of them are building them. So that's a very important demographic check. But that concentration mass of people in Hucknall is between Kingsmill, the City Hospital and NUH. It's a massively important area. It has great infrastructure links. That's why everybody's building there. But what it doesn't have is a real community hospital or community hub, and that's what it could do with. Incidentally, the County Council own the police station on Watnall Road, which makes an ideal site. And further along Watnall Road, where Torcard is, there is some land available at the back of it that's derelict land. It's just there for sale. So we need, as part of the strategy, to look at things like this, because a community hospital or community hub or practice in Hucknall will also help the people across the city of Nottingham, because they're all using the same services at City Hospital, Kingsmill and at Queen's Medical. So I think it's very important. And then, of course, going forward, after having a year of COVID, everybody keeps laughing at me, I was saying this, but we're going to have the COVID kid boom, aren't we, next? Because everybody's been at home. So, you know, clinical models going forward, we're going to be seeing an expansion of population over the next couple of years. We know that. So I do think that it's very important that you look at that specific area, because it affects a massive amount of people. And also, as well, I would be very, very keen to make sure that the finances are set up correct, and we don't end up with the same thing that we've got at Kingsmill, where last time we talked about this, I thought it was £1 million a week, and actually it's £1.2 million a week costing them, and it's a lot of money on that plan there. It's a disgrace, really, because that money could really be spent better elsewhere. And I know that's a governmental thing, but it's something that you, as the CCG, I can't do it. It's got to be you or the County Council that does it. So thank you for that, Chair. Thank you for indulging me.
Okay, thank you. I don't think there's a question there, was it? It's more of a statement. So I'll ask Muriel next then, please.
Yes, thank you. Thank you, Sarah and Lucy. And yeah, Lewis. I mean, this is such an enormous task, and I'm so impressed that you're moving it on during this COVID period. As you're probably aware, a similar process is going on in adult social care in the county around looking at how services will be framed post-COVID, what we've learned from it so far, and looking at kind of all age approaches to mental health and so on. I suppose there's sort of, I've got some general questions in a way. Just starting at the beginning in terms of a clinical model, I suppose in my mind, when we talk about the clinical model, I tend to think, rightly or wrongly, of a model of treatment that's clinical in terms of how do you treat a particular illness or condition. How does that link in with the decision, with the very concrete decisions about where you're going to have a new build? And is there already within the clinical models that's emerging in terms of decisions about maternity and children's services, A&E and so on, is there already a view of what the core building plan is going to be in terms of how much money the government is giving you for new build and how that will be spent? Does it all have to be spent on one new build, or is it money that, if you do have one new build, does it include money for refurbishing and changing other hospitals that are affected by where there's a knock-on effect from one key new build? I suppose my other question is equally broad in a way, which is about consultation. I think the start at this high level has been a good start. But in terms of a co-production model of not having too many decisions already determined before you go out for consultation, on the basis that a co-production model in the long run should save money, because although it's messy at the beginning in terms of having few parameters to what's already been decided, as it works through, it should actually save money, because we're then providing the things that the community really does want and need, rather than having to choose between 2 or 3 things that the specialists think are the kind of professional options. I just wonder how at this next stage that kind of model is going to be put into place. Is it going to be that you're going to put forward some options which seem to be emerging already, or are you going to start with service user groups and community groups with a blanker page to get what people with particular conditions and needs want out of the whole medical and social scene? Or are you going to take some particular decisions about buildings that you're already making? I'm sorry that it's a bit long-winded, but I struggle to get my head round how this whole process is going to work. So
thanks, Muriel. Who's going to take that on?
I can have a start, and I think colleagues might want to join in. So if I start council-wise with, it is really tricky. Form following function, and is the money determining what we're going to build, or are we really starting with a blank sheet of paper? And as you could imagine, it is kind of a bit of both. So I think when we came before, we talked about the hospital infrastructure programme, and there's a phase 1 and a phase 2, and we are in phase 2. And that does mean that the hospital, and Phil's here for the hospital, have flagged that they need to spend money on their buildings to remain safe and continue to provide services without any transformation. And I hope that that's very much the business of the hospital, but as a commissioner, and I would hope that as as representative members of our population, you would understand and support that, because great as the hospitals are, and the service they're providing, they are limited by the estate that they're operating from. And what they said, and I suspect, I can't remember the timescale, probably 2-3 years ago, is we need capital more than we can ever generate. So can we get a place in this health infrastructure programme? And I'm not going to sort of get into any politics. That is a programme that the current government have set up, and NUH are in that queue. So there is a sum of money allocated, but it's down to us to locally determine how that money is spent. So we hope there is still a sum of money allocated, but that is the health infrastructure programme. It's about 40 new hospitals that will be built one way or the other. So there is an element of it's constrained by the money, and it's exchequer funding. So to go back to Councillor Martin's comment, this is exchequer funding. It's not private finance. It builds the hospital, then the NHS runs it. So if you start with that framework, that's where we have to start. And I think probably to answer your second question, or one of your questions, the money that is allocated is for hospital buildings only, the acute hospital buildings, but we've got to make sure that we do what we have to do to community and primary care facilities to make that work as well. But the chunk of money for the health infrastructure programme in this case is allocated to NUH. So if that's the kind of where we're starting, and you're right, it is huge. If I sort of think next around the clinical model, and that's a very good point. It means different things to different people, doesn't it? And in my mind, the clinical model is it describes how services are provided, how you configure them, and then ultimately where they will be provided. And it's got a number of different elements. So we do look at international. So in terms of your question about how much can this genuinely be co-production, I think there will be an element of this that's prescribed. So I see it in 3 different categories. There are some things about NUH estate that just need to be replaced, whatever. So infrastructure is too old and it needs to be replaced to be safe. There'll be some, and that's we can't get around that. We don't want Nightingale wards, do we? I mean, I would suggest we don't want Nightingale wards. Love them as personal affection as I've got for much of the city hospital. It's not the way to provide care. So we're going to have to replace those wards, and we will replace them according to modern infection control standards. That's probably not a conversation that you would have with the public at great length, because there's lots of best practice about how that should be replaced. Yeah. So that's the kind of givens. Then you get into the territory of what can we really determine locally. Some of the care models, there is international best practice, national, international best practice. So we would be saying typically this service, this is how it's provided. This is what happens in primary care. This is what happens in the community setting. This is the bit that hospitals do. Some of that is largely determined by best practice, but what I think you would do is you would go to the public and say, this is what best practice tells us about this service. Yeah. But there is some opportunity to flex that, because it is these things are never universally delivered in the same way. And then you would talk about that the bit that is kind of flexible within that best practice. And then there is the third bit that is actually this is down to us to decide. There will be some of that is down to the population to say, do you know what, and again, I'm oversimplifying, the overriding view of the population in Nottinghamshire is that they do not want to have to go to hospital sites for plain film x-ray. So now we can say, actually, that's fine if we can provide those in more diverse locations, and there isn't a blueprint to that. So I think not withstanding the fact this is massive and we're going to look at virtually every service that the hospital provides, there's the givens, there's the bit where there is a policy, and then there's the bit where really we can design it locally. Does that help? And,
yes, yeah, it does.
And, yeah. Sorry, I mean, think some of the services, like the really highly specialised cancer pathways, we would be ill-advised to say that in Nottinghamshire we want to do it differently. But what you might have some flexibility around is where bits of treatment are provided. But not maybe about some of the high-tech diagnostics and the surgical treatment. So sorry, I was going to. So hopefully that sort of covers generally your questions.
Yeah, actually, Lucy, I found that extremely helpful, because I think it's reminded me that actually if people are being involved in any discussion on a co-production level, it's best to know what the parameters are and to be informed about what is best practice internationally and what you specialists have got in your heads, rather than think it's more kind of acceptable if you go to people and say, just say exactly what you want and we'll deliver it. I think in the long run, people who are going to stick with this and think it through with you really value being told what the parameters are. And these are the givens, rather than, the government's giving us a lot of money for a new hospital, where would you like it to be? I know you wouldn't say that.
No.
But I think spelling out the parameters of where we can influence, your third point about local decisions, I mean, that's very important. And people will value it. But yeah, if we know if we understand the replacement work that's got to go on, all the work money that's got to be found for primary care, and then within that, what we can influence, I think we can work with that. Yeah. Thank you for explaining. Yeah,
that's brilliant. Thank you very much. We've got Stuart Wallace next.
Thank you, Chairman. I'll be brief because I think the questions put forward by Muriel and Lucy's answers took a long way of my comments. I am concerned, though, about what happens with Kings Mill. in that if we develop this, or if you develop this system that is working and really delivering, do we get the same systems across the two places? We're from Newark. From Newark, it's 22, 23 miles to get towards Queens. It's about the same distance to get over to Mansfield, etc. So we've moved around the county. So what are we thinking about bringing it so we have a system that is for the whole of us and not just for segmental parts of geographical part of Nottinghamshire? I fully support, I really do support that we need to know what community service and community provision actually is. We really do need to know what everybody needs to know, what is available, what people can expect. I sat in numerous meetings with the ICS where they talked about the third sector taking this up, that up and the other. No one's ever done an actual audit to find out what existed, and therefore there's quite a lot of shocks in there because these things have stopped happening. So those are two ones that come through. And one for Lewis. Have we ever gone down the exercise with people, and instead of saying these are different models that we're looking at, what do you think, of going the basics first and asking, what is it that you would like, what would want, and start from that point? Because obviously, as Lucy talks about, you wouldn't want to mess about with your cancer care, etc. and things. There are certain things that's written off anyway. The message has to be got over to people. People in Newark have never forgiven the fact that effectively the hospital here has been closed down, and I won't get into technology of it, etc., because the communications were never run properly. And you really do want the population over the next 4, 5, 10, 15 years, however long it takes to get all this into part, that they are with us. They are walking with us. They know where they're going. And it's that communication. Because in actual fact, you call them patients. I have never met anybody going to hospital who's patient. That's one thing they're not. The clients, you know, they are the clients. They are the ones that pay for it. So let's keep them informed. I haven't seen things go out this way, and I know this is a massive amount of work because people will always want to know what the answer is to the full thing when you're asking what the questions are, what the end part should be. So those are my concerns. But as I say, very concerned that across the county, we've got to have the same quality, same impact, the same drive.
Thank you, Stuart. Who's going to take that on? Lucy?
Yeah, I can respond to the question about Kings Mill because it follows on, I think, from what Councillor Martin was saying. So we are drilling down into data. I think they're called lower super output areas, aren't they? So we're looking at the population health data, and they're quite small. They're quite small units of population. And interestingly, Hucknall is an area, and Lewis might, I don't want to put you on the spot, but you might have something to hand. But Hucknall is an area where you look at it and you think actually the decisions we take now will determine which way patients choose to be treated, which way direction they go to be treated. So we are looking at and as Councillor Martin said, you know, we're going to have more young people as well as more frail older people. We're looking at all of that. And in terms of going back to your specific question about Kings Mill, Newark and Mansfield Community Hospital, they are very good facilities, and we would want to make sure that they're used for patients who can realistically get to those facilities more easily. But you're absolutely right, it has to be the same model of care. So we would want to be, you know, we know that Kings Mill, for example, 50% single rooms, fantastic hospital estate, very low levels of hospital acquired infection. If it provides the same level and standard of care, then it may be that some of the work that currently goes to NUH could go there. So I think we've got to make, what we do here is we want to have top class physical facilities across the county, but a consistent level of provision. Your comment, Councillor Warris, about Newark is absolutely why we're trying to do it this way. So, you know, Newark, I don't think absolutely health bodies at the time didn't take the population on the journey. I think Newark is certainly a hospital that we could provide more activity from. So, but you're right. I mean, we've got to make sure that these are, you know, this is the integrated care system. You, Councillor Norris, know this as well as anybody. We're looking at services for the population, and we're going away from we've got a trust doing one thing here and a trust doing something there. So I hope that gives you an answer. Okay. But to Lewis with the have we tried the what I suppose yes, I think, you know, within those parameters we are doing the kind of what's important to you, but I'll hand that over to you, Lewis.
Yeah, it's a good question. So do we ask what do you want rather than what do you think of what we're proposing? So we wouldn't phrase it like that. We would ask what is important to you in your maternity care, or what is important to you in your stroke care. So it depends on the exercise, it depends on the context. I think it's worth saying that for Tomorrow's NUH, the clinical model is also underpinned by the clinical community services strategy. So that was a much broader principles-based piece of work, which we did do a lot of public engagement on. So a lot of kind of small group work with stroke survivors, women of birthing age, to ask them about what was important to them in their care. It's difficult to draw a clear line between that feedback and something concrete that happened, because it tends to be fed into the principles that underpin the model. But the model is definitely underpinned by that earlier engagement. It's much more open and much more co-productive.
Yeah, I must confess, I'll go back to my thing of getting the message out. I'd like to see, certainly in Newark and therefore everywhere else, that we're seeing more and more people asking these questions. I'd love to see people in the marketplace, even though it's freezing cold, etc., 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 actually stopping people and saying, what is it that you want? We're thinking, what do you? Rather than do the formalised ones. I've seen the samples you've taken, I've seen the statistics you are, etc. I would also say to you, 47% of people are not quite sure where you're at. So you're only on there, you're really still on rocking. You haven't got them with you at all at the moment, if you look at your statistical puts. But we didn't see much last time. We really do need to see them this time, out there talking. And stick them in scrubs, because people love talking to them when they're in scrubs. Thank you.
Thanks, Stuart. And any comeback on that, or we're just taking that as a comment?
No, just, I mean, we'd love to be out consulting, to be assured. I mean, the colleagues have found some very innovative ways of communicating with the public in lockdown, but it's not the same as being out there, is it? So we would. I mean, I think we might come to this, Chair, at the end. But I think, you know, Councillor Wise is absolutely right. This is enormous. I keep saying it's probably the most important thing I will ever do. And it's starting to narrow it down. And I think we are to have those really detailed conversations. We're going to have to do that in themes. So I think we are going to have to say, you know, we want to talk about cancer, we want to talk about urgent care, we want to talk about, because I don't think you can do it. I don't think you can, it's really hard for people to engage when it's potentially everything that we do. So I think we can, when we can bring it down to themes, but of course I would also have to say that you can't redesign a system in silos. We've then got to bring it all up together and say, based on what you said about cancer, what you said about maternity, this is what we think it means. But I think we need, the next stage needs to be getting into that thematic, so we can have some real, because there is some really good stuff actually that we want to get out and talk to people about.
Thank you, Lucy. I've got Kevin Greaves next.
Thank you, Chairman. I'll keep it quite short. Will the separation of planned care and emergency care result in a loss of flexibility or de-skilling in surgery staff? The surgical staff? And also regarding staff, as we're touching on staff, the recruitment of staff, it just happens to plague the NHS, as we've seen the shortage of staff decrease over a number of years. And in Bassetlaw, especially with Bassetlaw Hospital and Doncaster Hospital that we're aligned to in this part of Nottinghamshire, staffing has been a major problem with our hospitals, and just like everywhere else. Now, Bassetlaw District Council has grabbed the initiative to set up a training college in Worksop to train staff, to help the NHS train staff. Now, wouldn't you welcome that throughout Nottinghamshire if other district councils was to do the same, to do their part in helping recruit more and more staff and train staff for the NHS for your areas in Nottingham. So what part are you doing to recruit staff in your hospital? Thank you, Chairman.
So if I pick up the general workforce question, and I don't know whether Phil Britt from the hospital wants to.
I'm going to say, I think that's detracting us from the actual theme of our consultation. I'd like to stay on subject, please.
So if I pick up the general point, your question about separation of elective and emergency is a very astute question. Best practice tells us now that if you can physically segregate, and it could be different sites, it could be different parts of the same site, if you can physically segregate emergency and elective care, you both it helps to manage the urgent care, but also protects capacity for elective care, and that's something that's very strongly coming out post-COVID. So you are right. I mean, if you have all your beds together, you potentially can flex them, but you've got issues around cross-infection, and you've always got the issue that when emergency care soars, then the planned care capacity gets used up. So that is one of those health policy issues, actually, and that's something, again, that we could talk to you about. That certainly best practice regionally is we need to maintain some segregation so that we've got some, protected planned care capacity. But it's a very good question. Your general question about workforce, I don't know, because I'm not a workforce expert, but I suspect we've got more staff working in the NHS than we ever had. But what's happened in time I've been in the NHS is they've got more specialised. So, and that is because healthcare has got more specialists. So I think what this gives us the opportunity to do is to recruit and retain those highly specialist staff. So a big part of this is to have that kind of focus on research and innovation, and that will help us when you look at that very highly specialised and nursing AHPs and doctors, to actually recruit and retain them. Medical students that train at Nottingham, they don't all stay in Nottingham, they often go. So we want to have a hospital of very high levels of expertise that will enable us to retain them. And I think your general point about would we welcome working with local authority around training hubs for support staff, absolutely we would. And but I have to say, this is a big part of cementing, attracting and keeping as much of the best workforce we can in Nottinghamshire. I think Phil has put his hand up, haven't you, Phil?
Yeah, just a couple of additional points on that. So as part of our decision-making criteria, there's a set of what's called desirable criteria, which we use to differentiate between the options when we're at that point. And one of the criteria we are looking at is the impact on our staff from the proposal. So it will be a consciously part of our evaluation is trying to understand which is the right model of care and right options going forward. The second point I wanted to make as well was, as well as the engagement that's been going on with the public and stakeholder groups, we've been engaging with our staff as well through this process, and it's something we've been doing for many months and years within the organisation. So really starting that dialogue with our staff to understand how these changes will help them in terms of workforce planning, better environments and everything else. It's a really important part, this, getting it right for our staff and ensuring we've got the right staff to support the clinical models going forward.
Okay, Lucy, you want to come back
Yeah,
in?
just to come back on that, I mean, clearly the Trust have an absolute need to bring their staff with them, but from a CCG perspective, I think examples, recent ones, maybe Chatsworth, we do need to take staff as part of our broader engagement piece as well, because they're not just staff, they're patients, they've got families, and they influence the thoughts and feelings of our population. So I think it's not, don't think this kind of staff engagement happening over there and the rest of the engagement happening here, it will all come together. But it is a very good point, and Councillor Greaves, I would be not being honest if I said we're absolutely confident we have, and we can keep all the staff we need, because you are quite right, and we don't know what COVID will do. We actually don't know. Will COVID result in a huge exodus of staff from the NHS, or could it make people think, crikey, that's somewhere we want to work? All we can do is put Nottingham in the strongest position to recruit those staff who remain or come into the NHS.
Thank you. I've got John Noddy next, please.
Thank you for that, Chair. Obviously,
sorry,
that's relevant.
sorry, Kevin.
Oh, sorry. Thank you for the answers to that. I did think it were relevant, Chair.
Okay, thanks, Kevin. John Noddy next, please.
Yes, Chair. It's sometimes hard to know where to start when somebody puts forward a paper like this. It's like you've got a jigsaw, but you have no idea what picture you're going to come up with when you put all the pieces together. It's, I suppose, a poison chalice, really, when somebody says, here's all this exchequer money, go and do something with it. Could you do a lot of that stuff just by reorganisation? Building a building is a structural thing. The thing that caught my eye was the idea that, if we do 100,000 operations a year and we want all the follow-ups to be in general practice, there's 100,000 consultations with practice nurses or practice GPs, etc. ICS must then change how we develop the community services, as Councillor Wise was talking about, that building a brand spanking new hospital does not necessarily change the actual care that you actually provide, and therefore it's that circle whereby the finances that exist within the ICS, where savings are made in one area, are transported and moved around into other areas to improve all aspects of care rather than just the one aspect of care. So I think it's a little bit at the moment like you decorate one room in your house and then all the other rooms start to look a bit dated, and then before you know it, you're having to refurbish the whole house. And I think that's what we're seeing here today, that once we have one suggestion put forward, it leads to another and leads to another. So I think it's very exciting. I think it's one of those wonderful projects that will keep Lucy and a lot of other people busy for a long time to come. And I just look forward to the more detailed plans coming forward, but it is quite exciting. Thanks.
Thank you, John. I think that was more of a statement, wasn't it?
It was.
Yeah, Councillor Butler then, please.
Oh, thank you, Mr. Chairman. Well, I'd just like to go back to the consultation side of things. I know we live in a world now where a lot of people like to go on social media and basically most people who go on there just having a good moan. Sometimes they name themselves, sometimes they don't. But I noticed that you received a few replies, so 100 or so comments, and then out of those only 70 or so were considered relevant. But some of the ones that you did consider relevant highlighted a few little concerns, basically complaints. I mean, there was complaints about no TV or newspapers on a ward where patients were perfectly able or capable of having such things, and it may well have helped them during their time in there. And also complaints and allegations about staff apparently not seeming to be doing anything, which I'm sure wasn't the case, but that may have been a perception. Do you do anything with those comments? Will you have followed those up, or what will you have done with them? Or do you just put them by as perhaps people saying things, keyboard warriors perhaps, who may not say things for real face-to-face? Thank you.
Just a general point before Lewis will answer that specific point. I think you do make a good point. It could be Emperor's New Clothes, couldn't it? We have all this capital and everything will get better. And I just want to assure you that that's not, we do not pivot the whole future of our health system on having this capital. We think we need this capital and we think we need new buildings, but on a day-to-day basis, the CCG's role is to work with the providers across the ICS to make sure that all of our services are as good as they can be, but doesn't get away from the fact that we'd really like to get this money to spend on the hospitals. But Lewis, do you want to talk about how we would deal with that particular type of feedback?
Yeah, 100%. That anything that's about specific service staff, or the hospital or anything like that is routed through and signposted to the right channel. So the patient experience team, complaints teams, so every comment is signposted to the right place. So nothing's been discounted. If it's not relevant to the questions that we're asking in the programme, it's been signposted to the area that it is relevant for.
And can I just come back, the comments that you received that you considered not relevant, I mean, obviously we don't need to know what those comments were, but how do you decide what are relevant comments and what are not relevant comments on this sort of thing?
So if the comments are relating to the programme or any of the questions that we're asking, we'll incorporate them into the feedback. Anything about an individual complaint about a service or a staff member, we would forward to the trust. There isn't a clear line between the two, so it is a judgment call. Some of them, if you've been through the comments, you'll see some of them are quite obviously in the complaints area and some are quite obviously in the project feedback area. Some are roughly around the middle, and then we'll make a judgment call on that with the relevant service or team.
Okay, right. Thank you.
Yeah. Right. Okay. I think that's everybody, isn't it? Yeah. Okay. Thanks very much. I think some of the comments there is been really good, actually.
Chair, sorry, I have been wafting around for a long time.
I can't see everybody. I can only see certain people. If you haven't put your hand up on the thing, I don't see it, Liz. Well, you're not up on mine, Liz. So sorry, I can't see it. Sorry. If you would like to go next, then please.
Thank you, Chair. Thank you. Brief. Excuse me. I just want to go back to the sort of consultation that's been done so far. Well, obviously, public engagement proposal, whatever. To me, it seems like it was a relatively small response, both from the general public and obviously from staff and stakeholders. I don't know what, Lewis, what you consider in terms of the numbers. And when you think, obviously, I mean, as Muriel says, as everybody on this committee, this is a huge, massive piece of work which will impact on people's lives for many years to come. So I'm just wondering what will, and again, at this point, obviously, it is more about principles than specifics that you've gone out with to some extent. And obviously the next consultation will have much more meat on the bone in terms of how this, what is proposed. So I'm just wondering how you would hope to improve on that response. And because, thousands and thousands of people, and yet if you total up what response you have had, what is it, much beyond 500? Thank you. Sorry, Chair.
No, sorry, I don't know why, Liz, but I can't see your hand come up. And if you're not on my screen, I don't see you. So it wasn't deliberate. I do apologise.
So yeah, the total number of people who've participated is around about 700 if you have the Health Watch engagement with the Commission Support Unit. On top of that, you'll have the groups we've visited. So for the amount of time that we've had a survey and events programme running, it's not bad. We can always do better. I think for the consultation itself, we'll run that over a much longer period and we will do much more promotion, so the numbers will be higher. What I would say about this phase of work is that we're as interested in the quality of the feedback as we are in the number of people who are participating. So a lot of the engagement has been, 20 community groups, 15 different organisations, boards, quite in-depth focus groups, phone interviews. So we've really been focused on conversations and quality of feedback, but it's a fair point on numbers. So we will be looking in the consultation to speak to much more people.
Lovely, thank you very much. Is that everybody now? Anybody else want to speak? Sorry, I'm going to put your hand up if you can. And I'm just waiting to see if anybody's going to tell me. No. Lovely, thank you. I think there's been some great comments there in terms of, and it shows the difference in the services throughout the county, actually, where we've got Councillor Martin wanting to have a community hospital in Hucknall, where I think the furthest you'd have to travel to a hospital from the centre of Hucknall is about 4 miles. To Newark, that's going to go about 28 miles, no matter which hospital it goes to. So it just goes to show how diverse it is in terms of that. Although, bearing in mind that Newark doesn't come under NUH. Yeah, but if you're looking at the bottom part of the Newark and Sherwood district area, they probably would go to Queen's Med Hospital rather than anywhere else anyway. So we are very much involved from up here in terms of going there. So, we're looking. with open eyes in terms of what you're planning and how it will affect and impact on our residents in the Newark and Sherwood area. I think that the next thing then really is that you come back to us in the spring with your consultation plan, so that we can have a look at that to make sure that it's it's what we sort of feel is the right approach, and go on from there. Is anybody else disagree with that from the committee? So I want to thank you for your time. It is a task and a half. I appreciate that. I think a clear vision and strong leadership is needed here in terms of pushing and driving it through, because you're going to get that diverse response from people that and everybody's got their own sort of points of view in terms of what they're impacted by. So thank you very much for your comments and questions. I'll then move us on. Thank you very much.
Councillor Martin has his hand.
Okay, that takes us on then to item 6, which is the work programme.
Thank you, Chairman. Would you like me to run through
Yeah,
that?
Martin Gately, you're going to introduce that, please.
Thank you very much. Okay, so I can confirm the next meeting is on the 9th of March, and we'll be looking at the NUH Maternity Services Improvement Plan. That's a pretty substantial item, which I think will take up a good portion of the meeting. Also going to be looking at the patient transport service performance stats. The other items that you've currently got listed, which are access to school nurses, children's strategic commissioning, and Fred Elderly at Home. I think we're going to have to defer those to nearby future meetings, because obviously with looking at the maternity, that's probably going to take up a vast portion of the meeting, and that's what the chair suggested to me he wants to do.
Yeah,
So
if you don't mind, I've gone down that route, because in previous meetings we've had members leave, and that's not really conducive to good scrutiny. And I appreciate we're all busy and we have to leave, so it's not a criticism of you. It's more of the trying to manage the fact to try and keep you all throughout the entire meeting. I think you should have been notified that I have requested that moving forward we have more regular meetings, so that we can keep the agenda a bit smaller and then scrutinise properly those items. Do I have any dissent on that from anybody? Just so I know, is everybody happy with that move forward? I mean, chances are it might not be me as the Health Scrutiny Chairman, but we'll see. And we don't know who's going to be on the Health Scrutiny, because the next one where that will come into effect will be after the election, I would imagine, not before it. So I thank everybody for all that. Right, I've got Councillor Martin.
Okay.
Councillor Martin first, please raise hand up.
Yes, Chair. It's just a point from the last agenda item, really. I fully agree with you about the lack of provision in Newark, I really do. But when we talk about the density of population in the city, Gedling and Broxtowe and Ashfield, it's much denser in a shorter space. I understand what you're saying. So my points were really about taking pressure off City Hospital, Kingsville, and the Queen's Med. That's what that was the point of it.
Okay, thank you. Councillor Wise.
Thanks, Joe. It's just a question about what's going to be included in the discussion about patient transport. Will it be both EMAS and the company that's taken over from Aviva? Will it be both areas of transport? Because I seem to have gathered quite a few complaints about the non-ambulance sort of transport over recent weeks.
Yeah, from memory, Mura, we had this as an item right at the beginning of me being chairman, I think, so nearly 4 years ago, and it was at the time when Aviva were losing or possibly losing the contract, and it was all pretty poor performance, wasn't it? So I think, unless Martin Gately wants to correct me, I think we're going to concentrate on who's taken over them and look at what their performance is like, to see if it is an improved service. Really, is that sort of along the lines we were thinking?
Very much so, Chair. And Councillor Wise, if you want to feed through to me any complaints or comments that you've got, so I can pass them on and we can get some briefing on them.
Yeah. Is that ERS? Is it called ERS, the service now?
I'd have to check, Councillor Wise. It's, I say, as I think Councillor Girling's pointed out, it's a while since they've been, and I've not obviously received the briefing from them yet.
Yeah, I think we're in a position. Sorry, Muriel, for jumping. I think we're in a position where they've had ample time to instigate their own processes and procedures and to measure their performance. So I think whoever it is will concentrate on that. If everybody's happy with that, is anybody against that sort of approach?
No.
Come on, Muriel, sorry.
Well, I'm not even clear now whether EMAS commissions ERS or whether the CCGs commission it. And the main complaint I've had recently is the vehicles being ill-equipped to transport people with disabilities, particularly if they've got electric wheelchairs. Just so the wrong vehicles turning up.
Okay, thanks
confusion. Confusion about the links between EMAS and I think it is ERS, isn't it?
Yeah, I think it is.
Whoever's taken over from Aviva.
Yeah, whoever it is, it doesn't matter. They're the ones that's coming to us. But yeah, I mean, that would be a good question to put forward. What's the links between? I think it's the CCG that actually commissioned them, though.
Is it? Yeah.
Yeah. I might be wrong, but we can. Well, that'll be a question, won't it? We can find out that. But I would have thought it's the CCG's.
Yeah. Well, I assume that.
Yeah, absolutely. Liz, yeah.
Yes, thank you, Chair. I think everybody is aware, but I'm very concerned about the sort of the mental health issues with young people as regards COVID and the impact, obviously, of being out of school for so long. And I'm just wondering, if there's somewhere we can get in, because, the children need to be back in school. There's absolutely no doubt about it. But I think we're going to have some quite long-standing issues with some children in terms of getting them back in there and what support that they can actually get in terms of CAMS, really, or mental health support, either within school or from CAMS. It's just having some clarity in terms of what is available out there. I mean, in terms of, is there sort of an action plan that they're putting in place in terms of how to deal with this going forward? I'm not really sure in terms of what it is I'm wanting here. Well, I am, but who delivers it, really?
Yeah, I get it, actually. I think that might be more of a we get them in to present what they're doing.
Yeah.
Yeah, so we understand what's being provided rather than a scrutiny. Would that be something?
Like an action plan going forward or something?
Yeah, and look at it so we understand, and then that's something we can pass on to our constituents, isn't it? Do you get that, Martin? Happy with that?
Got it, sure, I've noted that.
Yeah, I think that's probably something we can try and fit in. Probably be the new administration now, I would have thought, and maybe on the first agenda of the new administration, because that's going to be about the time that we start to come out, I would have thought. Are we all happy with that? Why are you laughing, Muir? I don't mean coming out. I mean coming out of COVID.
No.
What are you saying, Keith? What are you saying?
No, I was thinking of coming out of COVID, but I just still think you're being a bit optimistic.
Well, probably am, but there's got to be a point of where. I mean, I think it's one of those things that we need to be ready for, rather than do once we're out, isn't it? So it probably is the best time to do it as a point, because by May, I think even would have had my injection by May, because I'm of that age group where I should be done by then. So we will start to see a loosening of things, I would have thought. Fingers crossed, but we'll see. So yeah, if we look at, if Martin Gately will put that on, maybe to be considered by the new committee in fairness.
If the elections don't take place, we might all still be here, mightn't we?
Oh, I have my view on that, Muriel. I think it's ridiculous that we're having an election, taking people out of key places that's dealing with all this at a time when actually we should have that stability.
I absolutely agree. Yeah.
Yeah. Hey ho. We're only lowly councillors, aren't we? but yeah, I totally agree with you on that point. But yeah, anybody else? I've got John Doddy's got his hand up.
It was only following on probably from what Liz was talking about, one thing and another, the variety of different areas that are under a huge pressure, like the mental health, etc. Just from an observational point of view, every morning when I click on my pathology, the amount of pre-diabetics that are cropping up every day, and those pre-diabetics who are going on diabetes every day, I've never seen the like of it before. Lockdown has created this sort of wave, probably related to eating, probably related to weight gain, probably related to inactivity, probably related to the whole lot of those. But down the line, we are facing an enormous amount of new diabetics. And I think that that's just one. I mean, Liz will be talking about the mental health of the teenagers. Somebody else could be talking about, lots of other things. But that is a daily reminder that I see, and whether or not that's something that the public health needs to invest in terms of actually doubling the obesity services or the dietetic services, etc. There is a real problem, a daily problem, and whether or not it's scrutiny, we should be actually asking at this early stage whether or not, if public health found it rightful to put £700,000 into drug and alcohol services, which they did recently, are they putting enough down into the general health of the population? It's just something of great concern to me.
Okay, I think that's a good subject as well. Actually, if we could put that on, Martin, as a diabetes, the increase in diabetes, what the plan is to help combat that. Really, I think we'll look at a better title probably. But anybody got anything else they'd like to put on the work programme? This is obviously going to give the next committee a lot to do, but hey. No, that's it. That concludes the meeting. Thank you very much, everybody, for your input. Actually, it's a quick one for us. So thank you for that.
Is this our last meeting, Keith?
No, we've got one more, haven't we?
3rd of March, haven't we?
Yeah, we've got one more, John. Don't worry, I'll thank you all properly on the 3rd of March.
Okay.
Thank you, everybody. Take care. Bye-bye.
Thanks, everyone. Goodbye.